Welcome to the video answers for Part 1, question set 8. Let's get started. First question, a child arrives at the ER in hypotensive shock after taking his dad's phenoxybenzamine. The intern on call orders the nurse to get her a pressor, stat. The nurse informs the intern that there are two pressors available in the ER, epinephrine and phenylephrine. Which one will be able to increase the blood pressure of this pediatric patient? So this is a pretty tricky question because it requires you to understand and think through a lot of different things. First of all, what is phenoxybenzamine? Well, it's an alpha blocker. It's going to block alpha receptors and decrease blood pressure because of decreased peripheral vasoconstriction. So that's why it might cause hypotension. Then, what does epinephrine do? Well, epi is both an alpha and a beta agonist. Remember that. And then what does phenylephrine do? It's a pure alpha agonist. So one way to look at this question is to say you've got hypotension from alpha adrenergic blockade, so just give some epinephrine, right? But epinephrine is going to act on the alpha receptors and the beta receptors, both the beta 1 and beta 2 receptors. Now, beta 1 stimulation will stimulate the heart some, but stimulation of beta 2 receptors on vascular smooth muscle is going to make those peripheral vessels dilate. Blood pressure will actually drop a little bit, so that's no good. You don't want to reverse alpha 1 blockade-induced vasodilation only to be left with beta 2 induced vasodilation. So in this case, it's better to give phenylephrine because it's a pure alpha agonist. It's not going to induce any beta 2 mediated vasodilation the way epinephrine will. Next, you recommend that your patient, a 51-year-old woman, begin taking a calcium and vitamin D supplement in order to prevent osteoporosis. What are the steps in the conversion of vitamin D to its active form in the body? So vitamin D can be obtained from sun exposure, from food, from dietary supplements, but it requires 2 hydroxylations in the body in order to be biologically active. So first, the liver converts vitamin D to 25-hydroxyvitamin D, also called calcidiol. Then the second reaction is in the kidney, which converts it to 1,25-dihydroxyvitamin D, which is the active form. It's also referred to as calcitriol. And then by what mechanism does vitamin D help prevent osteoporosis? Well, one effect of vitamin D is to stimulate calcium and phosphate absorption from the gut, so that the calcium can then be put into the bones. So if you don't have adequate vitamin D, you're not going to be able to absorb the calcium supplements as effectively. Next, what landmarks are used when placing an internal jugular central venous catheter? So where's the internal jugular vein? In the neck. So you're going to find the sternocleidomastoid muscle, which has a sternal head and a clavicular head. Then you visualize a triangle that's bordered by those two heads and the clavicle. You're going to place the needle at the apex of that triangle at about a 30-degree angle from the skin. Then you're going to aim the needle toward the nipple. Now, during the procedure, you need to palpate the common carotid artery just medial to the needle. Make sure you're not going to puncture that artery. When you place a central line, you always want to know where the artery is. Even if you have to spend 5 minutes finding the artery, then spend 5 minutes. Never ever pretend that you found the artery prior to placing the line. Make sure you know where that artery is. Next, at times, bupropion can be added to an SSRI for treatment-resistant depression. What can occur if a monoamine oxidase inhibitor is added to an SSRI? And then what's the treatment for that condition? So SSRIs are inhibiting reuptake of serotonin, and then MAOIs are inhibiting the enzyme that's supposed to break down serotonin. So the result of both of these classes of drugs is to raise serotonin levels, which is really helpful in treating depression. But unfortunately, this combination can make serotonin levels too high, and that can lead to something called serotonin syndrome. Serotonin syndrome is characterized by tremor, hyperreflexia, and muscle rigidity, or clonus. And then all that muscle activation can raise the body temperature so that the patient can get hyperthermia. They can also have diaphoresis, flushed skin, agitation, seizures, and cardiovascular collapse. So this is really a bad, bad deal. So how do we treat this? Well, you're going to stop the serotonergic drugs, obviously. You're going to sedate the patient with a benzodiazepine like lorazepam. Then they're also going to need supportive care like cardiac monitoring, oxygen supplementation, IV fluids, and so on. Then if all else fails, you can give a drug called cyproheptadine, which is an antihistamine that also blocks the serotonin receptors 5-HT1A and 5-HT2A. Next, clavulanic acid, sulbactam, and tazobactam aid penicillins in their activity against bacteria through what mechanism? Well, those are all beta-lactamase inhibitors. So penicillins and cephalosporins are beta-lactam antibiotics. They have a beta-lactam ring as part of their chemical structure, and that beta-lactam ring is important to how these drugs interact with the bacterial cell wall and then prevent cell wall synthesis. So one of the ways that bacteria can become resistant to penicillin is to produce an enzyme called beta-lactamase, which actually breaks down that beta-lactam ring. Sometimes you'll hear it, the enzyme called penicillinase. It's the same thing. Beta-lactamase, penicillinase, same thing, two different names. So these three drugs, clavulanic acid, sulbactam, and tazobactam, will all inhibit that beta-lactamase enzyme. So they help reduce bacterial resistance to penicillin. And then just so you've heard the specific combinations, clavulanic acid can be paired with amoxicillin, and that drug is called Augmentin. Clavulanic acid can also be paired with ticarcillin, and that drug is called Timentin. Sulbactam is paired with ampicillin, that's called Unicin. And then tazobactam is paired with piperacillin, and that's called Zosyn. All of those drugs are very, very commonly used, especially in the hospital. Next, a patient presents with a 1 centimeter painless mobile mass in a right parotid gland. You inform the patient that most tumors in the parotid gland are benign. What's the most common benign tumor of the salivary gland? Well, it's a tumor called a pleomorphic adenoma. The next part of this question says, what's a Warthin's tumor? So a Warthin's tumor is another type of benign parotid gland tumor. It's a cystic tumor with heterotopic lymphoid tissue that's trapped inside salivary gland tissue, and that can form germinal centers just like a lymph node. So it almost looks like a lymph node that's trapped inside the parotid gland. And then, what cranial nerve goes through the parotid gland? This is cranial nerve 7, the facial nerve. It doesn't actually innervate the parotid gland, but it passes right through it. Next, membranous glomerular diseases involve thickening of what structure? Well, it's the glomerular basement membrane. Membranous membrane, pretty straightforward. And then the next question goes back to the salivary glands for a second. Which bacteria are most commonly responsible for sialadenitis? The bacteria are Staph aureus and then also the Viridans strep. And then what condition most commonly predisposes a patient to sialadenitis? Most commonly, sialadenitis is secondary to stone obstruction of the salivary gland duct, which is a condition known as sialolithiasis. Next, what important secretory products are secreted from the following cells of the GI tract? So the first one here is G cells, and they secrete gastrin, and they're found in the antrum of the stomach. I cells secrete cholecystokinin, or CCK, and those are found in the duodenum and the jejunum. S cells secrete secretin, and they're found in the duodenum. D cells secrete somatostatin, and they're found in the pancreatic islets and also in the GI mucosa. Parietal cells of the stomach secrete two things. They secrete gastric acid, and they also secrete intrinsic factor, which is necessary to be able to absorb vitamin B12 in the terminal ileum. And then the chief cells of the stomach secrete pepsinogen. And our last question, an 88-year-old man arrives at the ER after he fell and struck his head. He has a history of atrial fibrillation, for which he takes warfarin. That's a very important drug to know about. And why do we give anticoagulation like warfarin to atrial fibrillation patients? To reduce their risk of stroke. So in this patient, non-contrast CT of the head reveals subarachnoid hemorrhage. What's the antidote for warfarin anticoagulation or warfarin overdose? So this patient fell, has a subarachnoid bleed. That's one of the big dangers of chronic anticoagulation. So how do you reverse the anticoagulation with warfarin? Well, there are two things we can do. You have to know how warfarin works. Warfarin inhibits the production of vitamin K-dependent coagulation factors, which are factors 2, 7, 9, and 10. So one thing we can do to reverse the effects of warfarin is to give vitamin K so that the liver can start making those factors again. That's going to take several days, right? In this patient, you need to stop bleeding and start clotting immediately. So you're also going to give coagulation factors. The way we do this is by giving fresh frozen plasma, or FFP. So they've taken donor plasma, they've removed all the cells, so it's just plasma and plasma proteins, and that includes the coagulation factors, and they've frozen that plasma, so it's fresh frozen plasma. So to reverse warfarin, you give vitamin K, either oral or subcutaneously, and you can also give FFP. And then the antidote for a heparin overdose is a drug called protamine sulfate. So that brings us to the end of question set 8. Now keep after these questions. It's really going to help you when we get to the video lectures in part 2 of the course. I'll see you next time.